Good afternoon, everyone, and welcome to the Missouri Board of Pharmacy's webinar today. I'm Tom Glinsky, Chief Inspector with the Board of Pharmacy, and today's webinar is our compliance update with a question and answer session at the end. With me today are Inspectors Andy Miller and Dan Vandersand. Andy is the inspector for part of Kansas City and Northwest and Central Missouri. And Dan has the St. Louis area along with a couple counties up in northern Missouri. All participants are in listen only mode. If you have any trouble connecting to the audio, you can, on the GoToWebinar toolbar, you can switch to telephone and it'll give you dial-in instructions. This CE has been approved for today's webinar. You must be logged in under your own username to GoToWebinar in order to earn CE credit. I'll give further instructions at the end of the webinar. Just a reminder, we do not report CE to the CPE monitor, so save your certificates that we will email you after the webinar. Handouts are posted in 2 spots. You can find them at the board's website under upcoming events, and they're also found on the GoToWebinar toolbar on your screen. If you click under the handouts, you'll see a PDF of today's handouts. We do make a recording of all our webinars. You can find them under News, Publication, and Resources link on the board's website. We have an extended period for question and answers today, so if you'd like to send us a question, go to your toolbar, type it in and hit send, and we will get to those at the end of the webinar. So today we have the webinar broken down. We're going to take a few minutes and talk about some specific items. Andy's going to talk about take-back receptacles. And then I'll give you an update on technology-assisted supervision and then some of the things, common things we find on inspections. And then we'll go into our question and answer session. So now I'm going to turn it over to Andy.
Hello. So I'm just going to go over medication take-back receptacles with you all. We've had a lot of interest brought here to the board about the medication take-back receptacles, which is fantastic. But with any new thing, there's been a bit of a learning curve for people along the way. So I'm just going to go over some things you need to take into consideration before you get a take-back receptacle, and then some considerations you should have once you have one implemented in your pharmacy. So the first thing you're going to want to consider is whether you're going to allow patients to bring in controlled substances or not. So you do have the option of limiting the drugs that are dropped off in your receptacle to be non-controlled only, or a mixture of controlled and non-controlled. If you choose to allow controlled substances to be dropped off in your receptacle, then you're going to need to amend your DEA registration to add collector to that license. And then you'll have to notify BND in writing, and they'll have to issue an approval for you to collect those as well. After that, you'll need to obtain a proper receptacle, which is going to be a substantially constructed permanent outer box or container with inner liners. So that receptacle is going to need to be able to lock to keep the contents secure. And there should be some sort of one-way opening so that the public can put items into that inner liner, but they're not able to remove them, kind of like how a postal service mailbox works. And those inner liners have some security requirements as well. They need to be removable, they need to be waterproof, tamper evident, tear resistant, and you shouldn't be able to view the contents from the outside. And there needs to be some sort of permanent, unique number or identifier on those liners. Once you've got your receptacle, you're going to have to decide where to put it. You're going to need to put the receptacle inside the physical pharmacy building, and it needs to be accessible to the public. It does need to be away from exit doors and should be visible by pharmacy staff at all times. And then you're going to want to securely fasten that to some sort of permanent structure like the floor or the wall. You'll need to put some sort of signage on your take-back receptacle. either prohibiting controlled substances from being dropped off in it, or if you're accepting controlled substances, you're going to have a DEA compliant sign that says that there's certain substances that are not permitted, such as Schedule 1 controlled substances that are not lawfully possessed by the ultimate user, or other illicit or dangerous substances. We do require you keep specific records for your drug take-back receptacles. The first thing on the list technically is not a record, but it falls within the paperwork category, and that is policies and procedures. These policies and procedures should, at a minimum, cover all authorized destruction procedures and methods. And that's something you should develop within your own pharmacy. I've seen some companies that provide receptacles do provide some sort of policies that people sign off and agree to when they accept the receptacle. You can use those, but just make sure that they actually do mirror your own authorized destruction procedures for your facility. Liner records, I just have an example over there to the right of the slide there. This is from MedSafe. They need to have the unique number or identifier for each liner on them, the date that the liner was installed, removed, sealed, and destroyed, the location address where the liner is, or the take-back receptacle is located, the size of the liner, and the names and signatures of all witnesses for each required step. Now, all those steps I mentioned, installation, removal, sealing, and transfer, they all do require two licensees to, licensees need to witness that, and their name should be on that record. And I've also circled a few things on that example liner record to the right that commonly gets missed that I notice on inspection. So a lot of people forget to put the size on it, or they forget the liner number, so we have no idea what the record's for, or the address where the liner is at. A lot of places like MedSafe will provide you some sort of example, or maybe a little stockpile of liner records you can use. Check them over. If they meet all of our requirements, go ahead and use those, and that would be fine. Also, you'll need to perform some sort of annual inventory of your liners. This includes the date that you took the inventory, the quantity of liners, the size of those liners, and each liner's unique ID or number. This is something that's often overlooked for people who have got their brand new receptacle. So I recommend that you take this inventory at the same time you do your annual controlled substance inventory. Just makes it easier to remember. You definitely don't have to do it on that same date, but it's easier to have one inventory a year than two. And then just make sure to keep those records for 2 years. As far as security of the drug take-back receptacle, like I talked about earlier, the opening should allow patients to be able to put medicines in, but not be able to take them back out. This is a picture I took on an inspection recently where I opened up the door for the chute that goes down into the inner liner, and it looks like maybe the patient just didn't shove them down all the way, or maybe the liner is full. So those are things you're going to have to be cognizant of. So pharmacies should be keeping track of how full their liner inside the receptacle is getting, so we don't have any overflow. And then check and make sure that the chute is clear, because patients might not always think to check that themselves. Other security requirements for the receptacle: it does need to be locked when the pharmacy is closed. I have an example of a take-back receptacle here on the right. I'm not talking about those large locks on the bottom. Those should always be locked unless you're removing or installing a liner. I'm talking about that little lock to the right of the door, the chute that the patients will use to put medicines in. Patients should not be able to drop off any drugs into the receptacle when the pharmacy is closed. So this is just one possible way you could comply. There's other designs, and that's fine as long as it locks. We mentioned the liners have specific security requirements, and that's the annual inventory and those specific security features I mentioned earlier. And then sealed liners. So this is going to be the full liners that you've removed from the receptacle and sealed up. Those must be stored under lock if there's controlled substances inside. If there's only non-controlled, then you can store it in a controlled access area, and that can be kept in the pharmacy no longer than 30 days. So on inspections, something I commonly see is that pharmacies are removing these liners and just putting it somewhere in the pharmacy. That does not count as being under lock, which is required for the controlled substances. You need to put it like in a locked closet, a locked office, something like that. If you don't have a space, you could always put it seal it up and put it right back in that drug take-back receptacle, lock it up and put a sign that it's not available for a few days while you're waiting on FedEx or UPS or whoever to pick that up and take it for destruction. Also, any theft or diversion related to the receptacle needs to be reported to the board within 14 days. There are a few alternative take-back programs that pharmacies could participate in. They may choose to place some additional receptacles in long-term care facilities. Those receptacles would be managed by the pharmacy, but there are some differences. In lieu of fastening the receptacle to the wall or the floor, you could just store it in a securely locked room or controlled access area, such as a med room. And the installation, removal, and sealing of the liners needs to be witnessed by either 2 pharmacy licensees or a pharmacy licensee and a long-term care staff. Additionally, that sealed liner can't remain at the long-term care facility for more than 3 days. Mail-back programs are also permitted. Pharmacies would provide pre-addressed postage-paid packages to the patient that meet certain security requirements. Then those patients would mail those filled packages directly to an authorized collector. They would not be sending them back to the pharmacy. And the other alternate take-back program would be if a pharmacy chooses to partner with law enforcement. So if the pharmacy does partner with law enforcement, they would be exempt from the requirements of this law as long as the collection area is under the law enforcement supervision. The law enforcement personnel is present whenever drugs are collected on site, and the pharmacy never takes possession of the collected meds. I also want to go over some of the prohibited activities related to these drug take-back receptacles. Pharmacies cannot put their own inventory in the box, so no unwanted or unused pharmacy stock items can go into the box. Also, you cannot place items into the receptacle on behalf of the patient. This has come up a few times with the COVID situations. We've had some pharmacies that have closed up their lobby, and so patients are only coming by via the drive-through. You cannot, even in situations like that, you cannot take items from the patient and go put it in the drop box for them. Also, pharmacies cannot be reviewing any of the contents of the liner. Once they go to take the liner out, it needs to be sealed immediately. Pharmacies cannot open it back up, x-ray it, analyze it, or open or penetrate the liner for any reason, and pharmacies should not be inventorying the contents. Also, pharmacies shouldn't be taking anything out and reusing it or reselling it. And finally, I want to let you know that the board does have a program where licensees can apply to receive a free receptacle and some limited destruction paid for by the board. I believe it comes with 12 liners, and these are DEA compliant, so you can't accept controlled substances in them. If you want more information on that, I have a couple websites there you can visit on the board's page, or you can contact one of your inspectors to find out more.
Thank you, Andy. Just curious, what as an inspector, what do you see are your most common issues on inspection with take-back receptacles?
I would say the top 3 is either not having a liner record at all or having an incomplete record, not doing any sort of annual inventory of the liners, and storing those sealed liners in the pharmacy, even though they contain controlled substances, not being under lock.
Okay. Well, thank you, Andy. We'll now move on. I'm going to give discussion on technology-assisted supervision. So the board recently revised some rules dealing with supervision of staff. That would be technicians and interns. They're required to have, you're required to have direct supervision of your staff, which means you're readily and immediately available, and you're able to provide personal assistant direction and approval while the tasks are performed. So those both are required. And then the rule also goes on to define what readily and immediately available means. And this is an or. You're either at the same physical premise, so you're physically there, or you use technology to communicate with and monitor the staff. And that's what I'm going to talk about today, is the use of technology to supervise your staff. So the technology must be sufficient in order for you to communicate and monitor. This, the best form of that would be video and audio combined, but that's not required. You can use just audio. which could just be a cell phone that you're able to communicate with the staff with the cell phone. It is totally left up to the pharmacist's professional judgment and discretion. Also involved in that would be the pharmacist in charge, and the permit holder too should be involved in this decision on what activities you believe you can monitor using technology. You must be able to provide, whatever method you use, you must be able to provide personal assistant direction and approval when required. So you must be able to do those, and you have to ensure that whatever task that the staff is performing is being done safely and properly. So it really leaves, it's a standard-based approach where it's up to the pharmacist's professional judgment on how you do that and what you use. Now there are, later on I'll tell you some specifics that you can use where you have to have certain type. So this new technology assisted supervision can be used for your staff who's working in a pharmacy or working outside of a pharmacy. The things you cannot use it for is you cannot supervise staff who are compounding, that's both sterile or non-sterile. Anytime they're preparing any medication, dispensing or providing medication, and that includes stuff that's already been checked by a pharmacist, or use it to perform any kind of final product verifications. Those things all have asterisks by it because some of those, there are exemptions for certain classes, mainly F, renal, L, veterinary, Q, charitable, and R, remote dispensing site. There are some exemptions built into those rules for those. So what I'm talking about today mainly is going to be your standard Class A pharmacy or a Class B hospital who's doing dispensing that's under the board's jurisdiction. And then another thing is you cannot use technology to supervise a technician who is administering a vaccine or drug. That is strictly prohibited in those rules. So what can you supervise when they're in the pharmacy? Right? This is a list. It's not in a total list. This is just some of the things I came up with that you could use technology to assist. So this could mean the pharmacist is off-site and the staff is continuing to do these, and the pharmacist is using some kind of technology to assist them in supervising. So data entry, that could be patient data or prescription data. They could be contacting prescribers or patients, clarifying prescriptions or getting information from patients. They could transfer a non-controlled prescription to another pharmacy or receive one. They could not do a controlled substance though, only that has to be pharmacist to pharmacist. They can do reviewing inventory for outdates and other checks of the inventory. They could return prescriptions to stock. They could do drug ordering. They could receive the order from the wholesaler, process it, and put it away on the shelf. They could also stock or do any kind of maintenance on dispensing robots that are in the pharmacy. And then they could do any of those types of record keeping that's required by the board. So those are all things that could be done in a pharmacy while the pharmacist is using technology assisted supervision and is off-site. Now for staff working outside of a pharmacy, those fall under basically two types, and there's rules that apply to both of these. And one is remote data entry site. That's where a technician or intern is located at a site outside of the pharmacy and is doing data entry of either patient or prescription info into the computer system. We have a rule, it's 2.725, that is specific to this activity. It can be done at, examples would be at someone's home. They could be, a technician could be doing it at their home, or they could be at another location. But these have to be dedicated sites that you keep track of where they are. It's not they can just go anywhere. They have to be sites that meet the rule requirement. Right now, due to a COVID waiver, those sites can be outside of Missouri. But if the COVID waiver, once it's rescinded, the rule does require all remote dispensing sites to be located in Missouri. I believe the board will be talking about that at an upcoming meeting, but for now, once the waiver ends, remote sites will have to be back in Missouri unless the board makes a rule change. Non-dispensing activities is the other rule and the other type of activity that can be done, and it covers a wide variety of things, anything that's not dispensing related. 6.055 is the rule that talks about that, and locations where that could be happening is a staff's home, a clinic or a doctor's office, a long-term care facility. Could happen at a patient's residence, or you may have maybe a technician who just roams around and does it at various locations. Some things that could be done, contacting prescribers, prescription clarification, refill requests, and PA requests, contacting patients as others, things you could do. An example is community health worker. They don't have to be technicians, but we know some pharmacies are using those, using technicians as community health workers, and they could be out probably anywhere, patients' homes, at different locations doing that work. And anything they're doing, related to the practice of pharmacy would have to be supervised. So again, you're able to, any of these things can be done using technology-assisted supervision. You could have a combination of a technician who does both remote data entry, and they're also doing other things like contacting prescribers and stuff like that. So you could have a combination site that both rules would apply to. So for all staff that's being supervised with technology-assisted supervision, regardless of where they're at, they have to have employer training for the activities they're doing, and they have to have initial and annual documented competency assessments. It's up for the employer to develop those competency assessment programs, but they just need to make sure they're done and documented. And then for staff that's outside of a pharmacy, there's some additional requirements. I talked to you about you can use audio, but in this case, it has to be real-time audio. So you have to be able to communicate in real time on a phone type thing where you can talk in real time to them. And then staff outside of a pharmacy cannot accept a verbal or written prescription. That can only be done within a pharmacy. I would recommend if you're having people work off site that you review both of those rules for all the requirements, because I did not go over some of them. There's some related to security, reporting breaches and confidentiality. The remote data entry site requires a PNP, a policy and procedure, and then it also requires a data entry audit trail when the technician's entering any data outside. So, and then as I said earlier, it's the pharmacist in charge, pick and permit holder is ultimately responsible for the staff. So you need to be confident in the people you're having work out there. I remember on one webinar, someone asked, how do you know that they're going to do what they're supposed to? Well, that's on you to know the people that you have out working remotely have been properly trained, and you trust them to do the right things, and you have a way to monitor them to make sure that they're doing it correctly. So now I'm going to just briefly talk about some of the top inspection issues we see. I asked the inspectors to give me their top 2 inspection issues that they see, that they write observations up. And so I have in no specific order here. I have, I think, 5 of them. Expired drugs in active inventory. Again, this was the #1 thing inspectors commented on. As you can see here, here's an example of a recent inspection where an inspector found all these products were outdated on the shelf. So it's important that you have a process in place that your inventory gets reviewed on a regular basis. And you need to make sure staff understands what they're reviewing it for and when an item should be pulled. Another common observation is possible dispensing errors. As you're aware, we look at prescriptions while we're on an inspection. So while we're doing that, we're looking for a variety of things. But one is, was it filled as ordered by the prescriber? Was the right drug given, strength? Was it labeled correctly? And so if we find one that appears to be a discrepancy between what was prescribed and what the computer, the back of the prescription shows, we issue a quality assurance report. And so for the last fiscal year, this is the year ending June 30, 2001. We issued over 400 quality assurance reports, and here's the breakdown of what they were issued for. And of the direct incorrect directions, PRN is definitely the most common incorrect direction. It's either PRN being left off the label or PRN being put on when it was ordered as a scheduled med. So again, this probably goes back to the start at data entry on is it being properly entered there, and then two, did the pharmacist when on their final review or data entry review catch that error. So again, these are things to talk with staff about, give a refresher to them on the importance of data entry and then that verification process. Commonly, compounds improperly labeled. Again, we've been talking about this for a few years now, and I know this is a confusing thing. Inspectors say they have a lot of people ask about this. So the rule requires that the patient container has the name of all active ingredients on it. It doesn't have to be on the prescription label per se, but it has to be somewhere on the container. And it needs to be unabbreviated names. The drug name should be fully spelled out there. So it can be on the RX label, it could be in the directions, in the SIG, or it can be on an auxiliary label that's attached to the container, but it has to be somewhere on the container. Especially long compounds with a lot of ingredients, your computer system has a set amount of characters that could be a drug name, and there's no way you're going to get that all in there. So you have to come up with a different method to do that. Auxiliary labeling is probably one of the most common that we see, and then some people actually type it into the directions so it prints on the label. So an example of a compliant one would be a prescription that's labeled Dr. Smith's Bug Bite Cream, and that's what the name of the drug is, and that's what shows up on the RX label. But the pharmacy would then, with an auxiliary label, list the 3 ingredients, full name spelled out, listed, and that would apply that to the patient container. Some examples of non-compliant naming would just be using magic mouthwash only with nothing else on the container at all. You can call something magic mouthwash or Dr. Smith's cream, you can call it those, but somewhere on the label or on the container, you must list the ingredients. The next example is abbreviations, and there are some compounds that have 5, 6 ingredients in them, and it takes a lot of space to do that, but those have to be spelled out in full name. And then another example related to magic mouthwash, inspectors see that when a pharmacy does label it, they're actually labeling it with Benadryl or Maalox, implying they used the brand name, but the compound log shows that they used a generic. So you can't be putting brand names on the container if you didn't use a brand name. So those are some examples. We also have a question sometimes about, can you just call it Maalox antacid? That's not specific enough. There's lots of antacids out there. You need to be more specific. You can list the ingredients, the active ingredients of the antacid on there, or you could, if it's a proprietary name such as Good Neighbors double strength antacid, you could do something like that that's more specific, but just calling it antacid is not sufficient enough. Failure to void excess quantity refills when on a 7-day initial acute pain opioid prescription. So this is a BND Statute. The part in red says that they can write for 7 days, but after that, they have to have a consultation with the patient before they can issue any additional. So on a prescription that was written for 90 and you're going to cut it down to 21 days, that the remaining quantity is void. On a tramadol prescription, if it's ordered and you had to cut it down and that tramadol prescription has refills on it, those refills are void. You have to get authorization from the prescriber to do any additional quantity. And you'd be making a new prescription out of it then. And then I added here the most common compliance notice issued has to be for cracked flavoring lids. I see this probably once a week or more on compliance notices being issued, which amazes me because we have been talking about this for years now, how these lids crack. And you can see here some examples we find on inspection. I highly recommend you have someone check your flavoring section on a regular basis and replace those lids if they're cracking. Okay, so we're now going to move to the question and answer session. If you'd like to send us a question, go to your toolbar and you can type it in and hit send. So we did ask for questions to be submitted in advance, so we're going to start with those first today. Okay, Dan, you want to take some of the questions?
Sure, yeah, I'll do the first couple. First question we had was, do I have to report technician terminations if they quit or if their employment's terminated for attendance issues? Simple answer to that is no. The only thing we require you to report is anything the board could take discipline on. Does the board need to be copied on loss reports? Again, the answer to that is no, there is no requirement for that.
Next question we have is, can I transfer a prescription I never filled without entering it into my computer system? So the board's rule does not require a prescription number to transfer an initial prescription, but you will need to maintain a retrievable record for that transfer, and that can be electronic or hard copy. Also keep in mind that you cannot not transfer a controlled substance prescription that's never been filled. So that would not be an option for you with a controlled substance. Next question is, the board is allowing pharmacies to use nurses to administer COVID vaccine. Does this apply to flu also? So this is actually a topic on the agenda for the October board meeting, and I do expect the board will be issuing some sort of guidance on it after the meeting.
We have a question about MTS. Someone wants to know, could we review the requirements for physician supervision of the pharmacist under MTS protocol? And they specifically said in an ambulatory physician clinic type setting. So the MTS rule requires first that the physician have a practice site no greater than 50 miles from where the pharmacist is. And then the physician must review the pharmacist's MTS activities at least every 3 months. How that review is conducted is up to the physician and pharmacist, but the protocol should spell that out on what the method is on how they're going to review, how the physician is going to review that. And then the second part of this question asked, are there COVID waivers still in effect for the 50-mile rule? And using phone or video for that physician supervision. So I'm not aware that there was any COVID waivers that lowered the 50-mile MTS requirement that pharmacy has. So I'm not aware of any COVID waivers. Can you use phone and video? Yes, if that's how they want to supervise and review the work, they can do that. It would be up to them and you how that review is conducted. But the 50-mile, there is no waiver on the 50-mile requirement. Let's see, we have a question about counseling. Will an on-screen offer to counsel meet the board's requirements? The answer is no. The offer must be made verbally if the patient or the caregiver is present. I will say this is another topic that the board has for future discussions. So on this specific thing of could you use some kind of electronic offer to someone. So the board will be discussing that in the future. So stay tuned if we have some updates in the future on that.
And someone wanted us to provide a few examples of when a technician would be counseling a patient. These would be things like if a customer comes up and asks for an OTC recommendation would be one example. Another one would be is if a patient asks, hey, can I split this tablet, or can I crush it up and put it in applesauce or something like that. That would be another example of when a technician would be counseling a patient, which is not allowed. And then one we're seeing a little more frequently lately, because technicians are administering vaccines, is to provide some kind of guidance on that, like what are the side effects to this vaccine and things like that. And then things such as storage instructions or side effects of an immunization, or what do I need to watch out for. Basically, if it involves a clinical judgment of any kind, that would be an example of a technician counseling a patient. Next question is what counts as compounding and what does not. So we've got compounding kits and manufacturer products that are out there now, and they can get kind of confusing of when do I put this into my compounding log, when's it considered compounding versus just reconstitution. So if you're reconstituting an FDA approved product, and those are things like antibiotic suspensions or benzocaine, that would not be compounding, so that does not need to go in your compounding log. If you're using a compounding kit, such as a first kit, those basically, they come from a repackager and they're not coming from a manufacturer. So because it's coming from a repackager, they don't have to go through the whole drug approval process and that whole bit. Those are compounded products. They're just basically taking something from a big container and putting it in a small container and then shipping that out to you. So those all would need to be entered into your compound log, and those are compounding kits. And then Andy, I'll let you take the next question.
All right, we have someone asking about MultiMed packaging systems. So MultiMed packaging systems can look a lot of different ways. Those may be like the blister packs where all the patient's morning meds are in one blister, all the afternoons are in another, or they could be strip packaging. This person specifically wanting to know what you can do if a patient has brought the med pack back to the pharmacy for a therapy change and pharmacy needs to remove some of those dosage units from the med pack. So if a pharmacy chooses to amend a med pack, those removed meds cannot be reused, even on future med packs for that same patient. They need to be sent for destruction using a reverse distributor. You cannot package it up in a vial and send it home with the patient. You just cannot reuse those in any way. Next question is, does the Missouri Board of Pharmacy require compliance with USP 800? The current answer is no. The board will have to promulgate a rule to do so, and so I can't speak for any other agencies or organization requirements, but the board does not have any such requirement at this time.
All right, next question is, please clarify whether we are allowed to send a refill request electronically to a physician for a controlled substance. And this person said their understanding was that we should not, since the physician does not have to enter the drug. That's subject to DEA and BND interpretation, so we're going to punt that off to them and then let you ask DEA and BND that question. Next question is, when providing off-site clinic immunizations, do we still need to bring the immunization protocol along to the clinic? The answer to that is no, we do not require that. If you need to refer to it for some reason, it might be a good idea, like if there's an adverse reaction and you're unsure of yourself and don't know how what your protocol says on that, then it would probably be a good idea to bring it, but there's no requirement to. Next question is, for pharmacists, do we have to split our CE into one half completed in 1 year and the other half completed in the second year, or can all the CE be completed in 1 year? So the board requires 30 hours of CE to be completed in a 2-year period. We don't, when we're doing your audit, we don't break it down to, 15 has to be completed in 1 year and 15 the next. So our only thing that we're looking at is, have you completed the 30 hours of continuing education during that renewal period?
All right, next question we got is kind of a hot button topic right now. Can the board provide more guidance regarding ivermectin being prescribed for unapproved use treating COVID-19? So the board did issue a statement, and I'm just going to read it straight through for you here. It says the board does not have a position on ivermectin at this time. However, licensees may use their discretion when asked to fill a prescription they believe is questionable or not issued for a legitimate medical purpose. Along with that statement that the board has provided, they had provided links to guidance that was issued by FDA and CDC, who have issued some more detailed statements regarding ivermectin. And as always, if you need legal advice, please contact an attorney. Next question, with regards to telehealth or telemedicine, how do we verify a provider is licensed in the state of Missouri? So for any licensee in Missouri, you can go to pr.mo.gov and perform a licensee search. And you can look for prescribers, pharmacy staff, any of that thing. You'll be able to search for there. Is a phone call to the number that sent, let me see. Is a phone call to the number that is sent in and asking whoever answers good enough? I believe they're asking about verifying a prescription based on a phone number. That would be up to the pharmacist's professional judgment. Next question we have, what disciplinary action will the board take against a pharmacist or company for dispensing medication when the provider is not licensed with the state of Missouri? I'm not sure if this person is referencing a specific event, but the board does review each case individually, so I can't tell you what the board would do in this situation.
Let me just clarify. I think they were asking if the telehealth provider was not licensed in Missouri, which there is a requirement, but under a COVID waiver right now, that has been waived. So that makes it even more complicated.
We do have a couple, so that completes the questions that we had that came in ahead of time. So now we'll try to answer as many questions that are coming in as we can. First question we had was, when will pharmacist license renewals be available? The pharmacist license renewals are actually due on even numbered years. So that won't be until closer to October 31st, 2022. I think we usually send those out about 4 to 6 weeks ahead of time.
It's usually in August.
Okay.
If they're asking about their pharmacy one, those have been sent. If you don't have your pharmacy or drug distributor one, you need to contact the board and they can send you a paper renewal. You can go, they sent out email renewals this year.
All right, we have a couple questions regarding the drug take-back receptacles. First one says, does the take-back receptacle need to be locked if it's inside the pharmacy and not accessible to the public when the pharmacy is closed? Yes, that is an acceptable option. Our rule reads that the opening must be locked or otherwise made inaccessible to the public, so the drugs cannot be deposited in the collection receptacle when the pharmacy is closed for business. So if you have a locking gate or something that comes down that encompasses the drug take-back receptacle, that would be fine. Another one, can a pharmacist, what does limited pickup available for MedSafe and who is paying for the service? The limited pickup, the board will pay for 12 of the liners to be returned for destruction.
Yeah, the reason we have to say limited is if you exceed 12 liners that first year, we can't guarantee the board will send you any more that year, and we can't guarantee that the board will always send you liners. The plan is, as long as the funds are available, we will, but we can't guarantee that. What we can tell you is you will get 12 liners, and once those are gone, we can't tell you for sure after that. But the board's goal is to continue with, if funds are available, to pay for the destruction, which is, that's what a liner is we're paying for the liner that gets destroyed.
One question I had related to continuing education was, does everyone need to send in proof of CE, or will it be requested by the board? We will request it if we need your CE. We do an audit on that, and we will request you to send it in. So you do not need to send it in with a renewal. Another question. on an opioid 7-day supply, is it the first fill ever for the patient or just the first fill for the pharmacy? So if you know that that patient is opioid tolerant, they've been on it before, then it's actually just the first fill ever for the patient.
As long as it's been within the last 5 months.
Yeah, oh, good point. Yep.
So
Yep.
it's not once forever. It's if there's more than a 5-month gap into them receiving that drug, then it would start over again. So.
Some more questions related to those 7-day opioid limitations. I have one that says if a prescription was written for 60, 1 BID, and we can only fill 14, 7-day supply, then we must void the rest of that RX and obtain a new one. That is correct. So you'll void out any remaining quantity and any refills that the doctor had issued at that time on an initial opiate prescription. Also, I've had someone asking if the doctor sends in an electronic script for 7-day opioid supply, I'm assuming an initial opioid, and the same day sends another one for 21 days. The rule does say that the patient needs to be evaluated by the prescriber after that 7-day period before another prescription is issued.
Someone's asking about, can a pharmacist do remote entry without supervision? Yes, pharmacists can work remotely. They can do anything under the same rule that the technician 6.055 data entry would fall under that. Someone asked earlier about what pharmacists can do, because I only talked about technicians we do remotely. 6.055 was originally written just for pharmacists. It was amended to include technicians, and that's what I went over. So just a refresher, if you looked at 6.055, pharmacists can do all those activities listed there, and that's not everything. It's just a list of certain ones. Anything non-dispensing can be done by a pharmacist outside, as long as outside of a pharmacy permitted area, as long as they follow the requirements of 6.055. Someone's asked another remote question. For remote data entry, is audio communication as needed, or does it need to be continuous? The board, it does not have to be continuous. As long as they can pick up a phone and call and talk to someone in real time, that would suffice.
Looks like somebody just made a comment, says you cannot send pre-printed refill requests for controlled prescriptions, and yes, that's true.
Someone wants to verify telehealth providers must be licensed in Missouri. This telehealth statute says they must be licensed in Missouri. However, currently there is a COVID waiver that has exempted that requirement. So, but the statute does say that. So if the waiver gets done away with, they will have to hold a Missouri license.
I have someone saying that they prefer faxed transfers for accuracy and asking what would be a way to do this for controlled substance transfers and still meet the requirement for pharmacist to pharmacist. A lot of pharmacies will just call, one pharmacist will call the other to verify the transfer, get the information, and have them fax it over after that phone call has been made pharmacist to pharmacist. So that would meet the requirements for that. Also have someone asking regarding compounding, can triamcinolone be abbreviated TAC? No, you would have to spell that out.
Okay. We have someone asking for on quality assurance report, what's trends looking like over time? Is it going up or down? The answer is it's going up. Inspectors have been finding more of those. They want to know what's the thoughts on those trends. I really can't comment on that, but I can tell you the trend of we've been issuing more of those over the last few years. Let's see, someone's asking, in a mail order pharmacy environment, Basically saying, can a technician put in an over-the-counter item in the box without pharmacist examining it? Yes, that's, since it's not a prescription item that had to be verified, they could stick an over-the-counter item in there. Someone's saying they notice many urgent care practices have pharmacies on their signage. Is that legal? It depends on what their signage actually says. So using the word pharmacy, no, they couldn't. The word dispensary, they could. So unless they have a licensed pharmacy there, they shouldn't be using the word pharmacy.
Got a question. It says, can a pharmacist receive a verbal order outside of the pharmacy? The answer to that is no. You can only receive a prescription at a licensed pharmacy.
I have another question related to the 7-day opiate rule. Person's asking, what if the patient's been getting a prescription for hydrocodone 5/325, but then the next month changes to hydrocodone 7.5/325? Do we start over with that change in strength? No, you do not. The patient is not naive to hydrocodone, and so it's drug specific, not strength specific.
Someone's asking about take-back boxes at hospitals. Does the box have to be located within the pharmacy or the hospital? Since the hospital is licensed with the DEA as a hospital, not as a retail pharmacy or other pharmacy, we fall back on DEA allows it to be at anywhere in the hospital. It does have some places where it can't be, and it must be in sight of a hospital employee. And then they go to, can a hospital staff destroy medications that are left by patients or deceased people by putting them in the receptacle? I'm going to have to refer you to the Department of Health on that one. I'm not 100% sure if they can or not. I'm thinking staff could not put it in their form. I don't think. I don't know for sure. We'd have to refer you to Health, who would regulate how that's done in a hospital.
We've got a question. It says, if a controlled prescription is written for 30 with a refill, can you combine that and dispense 60 at once if the patient requests it? Answer to that is no, not without contacting the prescriber and making a new prescription out of it. And we had a question on pharmacists asking what they can do outside of a pharmacy. I'm going to refer you to our rule 6.055, and that will explain, what pharmacists can do outside of a pharmacy.
Someone's asking when the waivers expire. It's 12, I believe it's 12/31, the end of the year.
Yes.
More question on 7-day opioids. Let's see here. They want to know, is that a state or federal law? That's actually a state law. It's a BND statute. Someone wanted clarification, does it only apply to acute conditions only? Yes, it applies to acute pain, initial acute pain prescriptions. Someone wanted to know, did we lose audio feed? We have not had any reports of that. So if you're having trouble, it's probably on your end. Can medical marijuana products be placed in the take-back bans? I believe they are prohibited by DEA since they are not considered a legal controlled substance by the DEA. Okay, well, we don't have any more questions. Let's see. Someone's wanting, we just got a couple more in. Someone's wanting to know if a patient asks if technicians are vaccinated, can a pharmacist respond according to HIPAA? I don't know. That you would need to ask your HIPAA compliance officer that question or seek legal counsel. Someone wants to know about a script for a written by a Kansas nurse practitioner, and the patient resides in Missouri. Does the 7-day rule apply? The answer, it only applies to things that are prescribed here in Missouri. So the answer would be no. Okay, well, no more questions have come in. So we're going to go to the next webinar. Is going to be on Thursday, October 7th. Olivia Rush, PharmD from MoHealthNet's Program Integrity Unit, is going to come give us an update on activities happening in their unit there. We do make recordings, as I said, of webinars. We have all the ones from this year and previous ones on our website. We've had 4. We had a COVID update, a regulation and legislative update, and we did one specifically for technician. So those are all found on the board's website. To receive continuing education, you must complete the survey to earn CE credit. The way this works, if you haven't been on one of the webinars before, is do not close your browser. When I say I'm going to end the webinar, a screen will pop up and I'll ask you to hit close. Click close, but again, do not close your browser, and then the survey will automatically pop up on your screen, answer the questions, and click submit. If you do not receive the questions on screen, you can email us at compliance@pr.mo.gov. We'll send you the questions, but you must get the answers back to us within 24 hours to get CE credit. Again, reminder, we do not submit to CPE Monitor, and we will email your CE certificates to you in approximately 30 days. So I want to thank everyone for joining. Andy and Dan, thanks for participating in today's webinar. And I'm now going to close the webinar.